Thanks very much, Nigel. And I'd just like to thank the organizers, particularly my distinguished compatriot Alison Street, for giving us the opportunity to speak here on behalf of my talented colleagues over here on this important issue. These are my disclosures. I've only got one, but I'm always willing to accept any others which are offered. So, don't worry about it. Now, those of you who have attended yesterday the talk by Keith Tolley and today the extremely learned discussion by Alec Miners would have some idea of health technology assessment as it has pertained to our field. And I think that you would have some idea of what cost-utility analyses are. This is the most common form of health technology assessment. It measures outcomes in terms of the so-called QALY, the quality-adjusted life year. And health payer agencies around the world have established a sort of threshold for their willingness to pay for an intervention, which is generally marked at about $50,000 for the incremental cost of a QALY comparing one intervention to another. This has a long history, and we don't have time to look at it. This part of the slide is actually interestingly identical, although we didn't talk about it, to Alec Miners' summary of the cost-utility analyses which have been done for haemophilia in prophylaxis. And as he himself remarked, the picture is somewhat depressing in terms of the ultimate outcome of these studies, because they generally tend to exceed significantly the willingness to pay threshold of the payer agencies. You might think that this would mean that haemophilia prophylaxis would not be funded. We know this is not the case. We know there are reasons for this, and we might be able to discuss those later on. But for rare chronic disorders, these are problematic forms of analysis, and I think Alec gave the best exposition of this. There is the question of discounting of both the costs and the benefits, and this decreases greatly the effectiveness and increases the cost per QALY for something which is a chronic disorder over life. The instruments which are used to elicit utilities, generally from patients, or in our field, parents of patients, generally tend to underestimate benefits. This is well described in the literature. It is always the case that people with chronic disorders tend to want to, if I may say, not rock the boat, so that new innovations are not always judged as well as they perhaps should be. And there is always the question of the selective use of evidence, and I would suggest that the fact that all of these analyses have focused on one clinical outcome and one alone, which is that of joint bleed and damage, is something which needs to be reviewed. This is just a slide from the famous paper by Alec Miners, which seeks to make the point about the discounting, and it is a complex slide, and I would just make the point that when benefits, i.e. the quality-adjusted life year, are discounted at the conventional level of 3.5%, we get a very low acceptability in terms of cost effectiveness of about 10%, whereas when the benefits are discounted at 1.5%, the cost effectiveness acceptability goes up significantly. You will see the importance of this as I continue my talk. This is a summary of the utility measurements elicited from patients, inputting into the analyses which I have just mentioned. And basically the point I seek to make is that with recent exceptions, mostly the work of the Irish Haemophilia Society from Declan Noon and Brian O'Mahony, these have tended to kind of underestimate the benefits of prophylaxis versus on-demand, and there are reasons for this. And for this we have, I think, considering that we now have, thankfully, a population of middle-aged and rapidly aging haemophiliacs, approaching a demographic profile similar to that of the normal male population. I think that it is important for us to now look at the whole of life in relation to haemophilia therapy, and we have constructed a new cost-utility analysis, and these are the key features. And I think that it is interesting that in this Congress, these are all being elicited as being the hot issues of our time. The question of pharmacokinetic dosage, beautifully described in one of today's plenaries, the effect of inhibitor incidence, the question of discounting, and importantly the inclusion over the whole of life of the avoidance not just of joint bleeds but of other rarer but extremely serious effects of hemophilic bleeding. In relation to pharmacokinetic dosage, which as I shall show is very key to our model, these are again extracts of the papers cited in this morning's plenary by Dr. Collins, and you can see the effect of including something like alternate or daily dosage compared to less frequent dosage in the amounts of factor VIII which are used. You will see that in our model, which is a whole-of-life model, we have inputted for these periods exactly these levels of factor VIII usage. And this is a very important couple of extracts from the ongoing in terms of publication, but I believe complete Rodin study. This is the first extract from the Canal study published in Blood, showing that in fact prophylaxis leads to a decrease in inhibitor incidence. And this is from Dr. Go's published on the internet thesis. I'm sure it will be in the peer-reviewed literature very soon on the whole of the Rodin study. And you can see these differences in inhibitors. But more importantly, and of key importance in our model, is the protocol developed by Gunther Auerswald and colleagues in Bremen over the past few years, in which the prophylactic regimen is looked upon not as, so to speak, a treatment modality for the effective treatment of bleeds, which it certainly is, but for allowing a sort of low-level tolerization of the patients, utilizing modern concepts of the danger signals on the immune system, and in this way tolerizing patients before they are exposed to serious bleeds and the necessity of large levels of factor VIII. And this is the description of the protocol, and these are the relevant prevalences reported so far by Auerswald and colleagues in the literature, and this is again key to our model. So, like all models, our model depends on the validity of clinical assumptions, and this is another important difference from previous models, which is that the discount rates have been adjusted for the QALY from 3.5 to 1.5%, and this is on the basis of the admission by the UK very influential NICE authority, which sometimes is not so nice, in terms of rare chronic disorders over the whole of life. I'm afraid that there is no way of having a talk like this without showing you a slide like this, which is relatively incomprehensible, but this is the so-called Markov decision tree for the model, and basically what you're seeing here is the population of patients given therapy, whether on demand, on prophylaxis, followed over the whole of their lives with all the clinical courses and all the protocols for developing inhibitors or not inoculated into the tree. I do not have the time to explain the tree itself in more detail, but it is perhaps more easily understood in this, again, so-called bubble diagram, which is used in this field, in which you see the two populations of patients taken through treatment over the whole of life, having probabilities of surgery, major bleeds, and very importantly, the development of inhibitors on the basis of the data inputs which I have shown you before. And now we come to the last few slides which show the results. This is, as I said, a cost-utility analysis which therefore seeks to assess whether there is, quote, acceptability in the incremental cost-effectiveness ratio relative to a conventional willingness to pay of $50,000. And basically the good news is that in this model, the incremental cost-effectiveness ratio of prophylactic versus on-demand treatment over the whole of life is about $3,000, which effectively means that the cost effectiveness in terms of the conventional way that the payer authorities look at these things is acceptable. This is another nice graph. It's very nice to have this kind of software which generates graphs which you can immediately dump into a PowerPoint. And I think that this kind of graph was also shown by Keith Tolley yesterday, and it simply is the cost effectiveness acceptability curve, and you can see that for a willingness to pay of about $50,000, there is about 80 to 90% acceptability of cost effectiveness in this model. So this is good news. Now I'm going to say something about cost one-way sensitivity analysis. This is simply a way of testing the key assumptions of the model in relation to how much they influence the model. And so here we have the key assumptions in terms of utilities, in terms of the discount rates, in terms of the number of bleeds. We have actually been quite conservative. Most people would say that 5 bleeds per year in prophylaxis is probably excessive, but we tended to be conservative. This is cost of factor 8 extracted from public information, the pharmacokinetics and so on, the inhibitor rates and so on and so forth. And you can see from this sensitivity analysis that certainly the dosage is immensely influential. And if you go to higher and higher dosages, you get increased costs, which means relatively low cost effectiveness. The inhibitor incidence I have emphasized is extremely important. We survive on this model on the validity of Günter Auerswald's brilliant work, but I am confident in this. And then you can see the other variables and the effect, as you can see on this slide. And therefore, I come to the conclusion, and I think that it's fairly obvious from what I have said, that using the best emerging evidence that we have on the key parameters of dosage and inhibitor incidence and factor in the recently allowed discount rates, and also other things like the probabilities of intracranial hemorrhage and so on and so forth, whatever we could get from peer-reviewed publications, that the prophylaxis over life results in an incremental cost-effectiveness ratio, which is well under willingness to pay thresholds currently applied, and therefore prophylaxis is a cost-effectiveness option. Now, if I may say, Nigel, I had the philosophical feeling doing this work that we would sort of take the fight to the enemy's own ground, if I can be a bit dramatic here, and use the criteria which are used by the conventional agencies. But, you know, I find myself, I find some of these things unconvincing, because when all is said and done, why should we have to go through all this to basically continue to establish the fact that we need prophylaxis for life in order to make sure that people with haemophilia have a normal life? And I'm sure that more evidence regarding the key assumptions will contribute in the future, and therefore I encourage payers, policymakers, the treaters, but above all, the patients. Because we now have, as the slogan of the WFH, treatment for all, but I think it should be added and augmented with the phraseology, the treatment for life. And I just want to round off by thanking these distinguished colleagues, all of whom you know, Kathleen, for interesting discussions. I don't think she would agree with everything we've said here, but she gave us a lot of insight. Brian O'Mahony and Declan O'Loon for sharing with us their utility scores. I've emphasized the importance of Günter Auerswald's increasing clinical work on the tolerization model of inhibitors, and Keith Tolley for advice on actually making these models. And I thank you very much for your attention.